Hello, and welcome to MDIC's annual public forum. During today's session, you will hear an update on MDIC's Case for Quality program, including the CAPA Process Improvement Pilot Study and Leadership Engagement, led by MDIC Case for Quality Program Director, Alan Baumel. Please make sure to join in the conversation on Twitter by following at MDIC Annual Forum and using the hashtag MDICAPF 2020. Now, please welcome session moderator Alan Baumel.
Good afternoon, everyone. It's a pleasure to welcome you to today's installation of the MDIC Annual Public Forum. I'm excited to introduce two great panels that we have today, featuring representatives from industry and the FDA. On the CAPA Process Improvement panel, we have Kathryn Merrill, who is a Quality and Regulatory Program Director for Medtronic, based in Arizona, and the Program Chair for the CAPA Process Improvement Pilot Study. We have Dan Beuhner, who is a Director of Quality Engineering for Edwards Lifesciences, based at the Draper, Utah facility, and the first site to enroll in the Case for Quality VIP initiative, and the first site to go live with the CAPA pilot. We also have Marc-Henri, who is an engineer at the FDA, a subject matter expert for the Medical Device Single Audit Program, and a member of ISO's Technical Committee on TC 210 that developed the ISO 1345 guidance and published the practical guide on that standard. We also have Bleta, Vuniqi, who is a biomedical engineer and a key member of the Case for Quality team at FDA, Center for Devices and Radiological Health. The CAPA Process Improvement Pilot Study is focused on leveraging cross-industry best practices to recast CAPA as a more effective and efficient risk-based continuous improvement framework. On the Leadership Engagement panel, we have Pat Shafer, who is a Managing Director at Grant Thornton, team leader of the working group, and co-author of the Leadership Engagement Playbook. We have Jackie Torfin, who is the President and Principal Consultant of Quality Leadership Consulting and co-author and editor of the Leadership Engagement Playbook. We have Ramakrishna Pidaparti, who is an Associate VP of Quality and Regulatory Services for Medical Devices and Life Sciences at L&T Technology Services and co-author and editor of the Playbook. The Leadership Engagement Initiative is focused on educating and influencing medical device CEOs and key leadership to help them transition their organizations from a culture of compliance to a culture of quality. These are wonderful and esteemed groups that we have today. My name is Alan Baumel, MDIC's CfQ Program Director, and today's panel moderator. I'm pleased to now introduce our next presenter, Kathryn Merrill.
As Alan said, my name is Kathryn Merrill. I'm a Quality Regulatory Program Director at Medtronic, and I'm also the Program Chair for this CAPA Process Improvement Pilot. And I have to tell you, before we start, I'm actually pretty excited because 2 of our 3 sites will have begun piloting this week. This next slide really will give you a whirlwind tour of the MAKECAPACOOL program for those of you who are new to the topic. But after this, I have about 5 slides that go into the ongoing pilot activities that are continuing. And you'll also get to hear from a panel that I know you're going to enjoy. It includes the pilot site leader from our first pilot site, as well as 2 of our key members of the FDA team who have been instrumental in getting us this far. So to start with a program summary, the CAPA Process Improvement team really started because there's an industry-wide struggle resulting from the current CAPA framework. So basically, we've got thousands of employees that love to problem solve, but they don't necessarily want a CAPA. So the goal of the team was to leverage cross-industry best practices to fundamentally recast CAPA as a continuous improvement framework. So essentially, we wanted to ensure that we had efficient execution of improvements that matter. So this team really was extremely engaged. It continues to be very engaged, and it's a combination of MDIC, FDA, and industry members. We had over 25 members initially, and I think we have grown since then, and we have 14 different organizations from industry participating. And as we went to develop the risk-based framework together, we followed a structured process, and we had multiple face-to-faces. There was a lot of work that was done, but I wanted to highlight 2 of the things that really did influence the framework that we developed. The first one was an industry-wide survey, and the second was a benchmarking activity. So the industry-wide survey came back, and we went through all the information, and we identified the top 3 pain points that industry was and the regulators were experiencing. The first one was it's not clear when to open a CAPA. The second was it's not clear the relationship with the other systems, like the non-conformance reports or the continuous improvement processes, which caused overlaps. And there was also a lack of planned resources. And so we wanted to make sure that that was incorporated into the risk-based framework to help improve those pain points. The second activity that we completed that I wanted to give you sort of the highlights around is the benchmarking process. And with my continuous improvement background, this was one of my favorite parts of developing the risk-based framework. And this is where we had a chance to do 10 cross-sector interviews to non-med tech device companies that were known for their continuous improvement processes. So we talked to those in aerospace, in finance, in software, in automotive, in the semiconductor, and we actually got to talk to the ex-head of Shingo. So it was a pretty exciting activity that we did. We got a lot of information, and then we've filtered through that and came up with the trends or the themes within that information of what a good continuous improvement system would include. And just some of the highlights of what we got was like, when everything is important, nothing is. So it's important to be able to prioritize, to be able to put your effort on those things that really matter. And then each one of them talked about how it was important that at all levels of the organization, with the improvement activities that you do, that it would be essentially connected to the customer, so that there would be awareness of how that impacts the customer. And for us in the medical device industry, that would be the patient. And we wanted to be able to have a risk-based approach. They said they all had a way of identifying higher risk versus lower risk activities. And the last one is the concept that you would be able to open up problem solving or those activities to every level of the organization. And so those were the things that we wanted to facilitate as we went after designing a risk-based approach to CAPA. So the top right of the screen really goes after what we accomplished in the first year, and that's where we were able to develop a new risk-based CAPA framework. And at the same time, because we were able to work across industry, we identified quite a few different best practices for the CAPA process that were also captured in the white paper. We identified how the proposed framework aligned with the regulatory requirements to ensure that it met those requirements. We completed some retrospective reviews. It was really a paper process, but because of that, we recommended that we test this in a live pilot. And so that's where we are now. And this is a high-level summary of the pilot. I've got a few slides that go into it later in the presentation. First, it's a multi-phase pilot where we've got 20 sites that are permitted in the pilot. We have standardized pilot material sets, which I'll talk a little bit about later in the presentation. We have a regulatory engagement strategy. We have active data collection and surveys that really takes into account the need for anonymity for site data, but still allows us to get the data that we need to prove out the framework or to learn from it. And then we also have real-time feedback as a part of the pilot, which I'll talk a little bit more about. And the goal is by April of next year to have the data we need to prove out our hypothesis about the framework and to make any updates that we need to make to the proposed framework. And then there will be a white paper that follows. So I've got two slides that really give you a high-level overview of the framework. We're not going to dig into the details today, but just to give you a taste of it. The hope and the goal right now is that we will be able to have more issues that are addressed as a part of this framework, that it will result in faster problem resolution, there will be less burden and cost associated with that improvement, that we will enable stronger engagement, and we'll have excited employees, mainly around the idea that problem solving will be something that can be leveraged at all levels of the organization, from those that are closest to the product to up to senior leadership, that it's something that not just a critical few do, but we can roll it out to the whole organization. And the last one is the importance that as we propose a new framework, that it would remain compliant with the regulations. So this really is a very simplified version of the framework, but it can give you an idea, quick idea of what it looks like. And it really fits into two main flows. The top flow is for external events or quality events that are outside the organization's control, and high-risk trends that are potentially patient or user impacting get treated within what we're calling an external CAPA, which is really the traditional CAPA record you know and love today. The second flow is internal events with low risk trends can be treated in what we're calling a fast track CAPA, which can be embedded within the quality management system that it's identified. And this really allows for reduced cause documentation and a simplified effectiveness check. So this slide, as we build it, will talk you through a high level of what we're seeing in the pilot. This first part is really the enrollment. So as you can see, we have a diverse group of participants, and they have different numbers of sites that are included in the pilot. We have 15 total pilot sites enrolled, so if you are interested in enrolling or participating in the pilot, we would love to have you. We have 5 slots left. So Edwards Lifesciences is participating with 2 sites. Medtronic has 3 sites. We have Baxter and Illumina, and Stryker has 3 sites. Cook Medical, Alcon, Abbott has 2 sites, and Celanova. And we have a few more that are participating in our biweekly team meeting as they're making a decision on whether to pilot it or not. So this part of the pilot is something that we put together to help sites apply the framework. So we recognized just providing the flow chart or the white paper might not be adequate to make sure that we have consistency in how the framework is being deployed. So we developed a well-defined playbook that they can follow step by step. We have sample procedures, we have data collection tools to ensure consistency. And so if you do decide to join, or for sites that decide to join, they walk through a training of all the material sets that are available. So they all start at the same point, and then how they implement it within their own systems is something that they work through at their sites. So this last part really is one of the parts, and you'll hear a little bit about this in the panel, is really one of the parts I really enjoy about the pilot phase. And this is where we get real-time feedback on a bi-weekly basis from the pilot sites. And right now that's Edward Lifesciences and Medtronic that have started. But we're being able to share lessons learned and leverage this to improve the framework and its application. We've done a number of different framework clarifications. We've seen how it's been implemented. We've gotten lessons learned from audits that we've gone through on the framework, and we've had really strong collaboration in this bi-weekly meeting. So we're developing stronger solutions together. It really is something that is a powerful part of the pilot, the ability to learn from each other and really dig into the questions that people will have when they're executing the CAPA process. So this is the last detailed slide I have on the pilot, and I wanted to be able to give you a couple of data points around what we've seen with the pilot. So some of the lessons learned examples we've had, we have been able to exercise use of the audit memo, which is a standard memo you can give to auditors when they come into your site to give them a high-level overview. It connects them to an auditor hotline, which is basically the ability to email our FDA team members on the team and be able to ask any questions they may have, and that was very effective during the audit. We also had an opportunity to have the reduced level of documentation that's required in a fast-track CAPA was assessed during the audit and was determined to be acceptable during that audit. We had a 3-month progress check and verified that the framework application within the pilot site met regulatory requirements. And then the last 2 bullets really are around some of the learnings that the team has had. The first one is that sites that choose to do a corrective action when not required by the framework, and we're seeing this because it's easier to do corrective actions. We still know that those CAPAs need to meet regulatory requirements. And then the last one is around the risk assessment, tracking and trending and monitoring and measuring processes we've determined are really critical to a risk-based approach to CAPA. And so we'll talk a little bit more about that in the panel. So why should you sign up? There are definite benefits that we're seeing as a part of the pilot that you can take advantage of within your organization. And you can also, your voice can help shape the future of CAPA. So you'll be engaging with a team cross-industry with MDIC, with FDA, to really determine a way to shape a risk-based approach to CAPA. And again, we've got 5 slots left. So how would you sign up? If you do have additional questions before you decide to do that, you can leverage our online training that is linked to the MDIC site, and the link is here. You could contact your organization's MAKECAPA Cool team representative if you have one. If not, you can contact me as the program chair. I've got my email there. You could contact Alan Baumel, who can put you into contact with me as well. Once you've decided to join, you can provide written communication of your desire to pilot the process, and your communication should include how you meet the minimum enrollment requirements, which is that you have no OAIs or official action indicated, and you are in good standing with the regulatory bodies, so you have the applicable certificates. And then you would schedule your pilot training session with me, the program chair. So with that, I'd like to go to the panel. So I'd like to start with Dan and ask, what were some of the biggest differences your site is noticing as a result of the pilot?
Yeah, it's interesting. We've been doing the pilot for a few months now, and we really are starting to see some big differences. One of the big differences is that we just aren't needing to open as many CAPAs. Because of the way that the framework is set up and because of the decision process that we can go through, what we're finding is that we're able to use that to be able to focus our efforts more on the things that people kind of naturally recognize are the things that we do need to be worrying about, that we do need to be focusing on, and that we don't have to, we don't have to put so much effort into just taking care of, almost administrative kind of things.
Excellent. Thank you. The next question is for Bleta. So I'd like to ask, how are both the trending and the risk assessment process maturity critical to the CAPA framework?
Yeah, so Kathryn, since the beginning when we started doing the benchmarking and meeting with different industries and meeting with the medical device industry, as well as getting input from regulatory, so ORA, so Office of Regulatory Affairs, also provided input. We heard from all the different industries that a risk-based approach was critical in order to ensure that flexibility and agility to solve problems, and as well as pay attention to those or utilize the time for those issues that are higher risk that have a bigger impact. We've noticed that the pilot, so initially we discussed that the sites that will enroll in the pilot would have to have a matured trending and risk management system. But what we've learned is that the pilot also highlights some of the weaknesses or the areas that can be improved to strengthen the quality system that a organization has implemented within their organization. So we're continuing to learn. We continue to believe that risk-based approach is critical in order for any quality system to be matured. And that's not only for CAPA, but it's essentially it's the same throughout all the systems that an industry might implement as part of the quality system.
Good. Yeah, thank you, Bleta. And Dan, along those lines, do you have any examples of how the pilot has helped strengthen the risk assessment processes or your trending processes? Has it exposed anything that you needed to improve within your systems?
It has helped to highlight to us areas where, we've done in our situation, we've done a pretty good job, I think, of being able to identify and define our product-based risk assessment process. But what the pilot program has kind of exposed to us is that, there were ambiguities that we needed to work through when we were talking about compliance risk. And
yeah, the next three questions are pretty much for Dan, and we did that deliberately knowing that listeners would be interested in a site that had already started piloting it. And so the first question, Dan, is that how have you adopted your system to document information as specified in the Fast Track CAPA?
Yeah, sure. So, it started off, with a simple idea. Let's try to keep this as simple as possible. We created a supplemental procedure for defining what these Fast Track CAPAs were, and then defining what needed to be included with those Fast Track CAPAs. In our particular situation, we have an electronic software system that helps us to manage both NCR and CAPA, and it's an integrated system between those two subsystems. And we were able to more or less carve out a spot within our nonconformance system where we could contain the documentation of what was going to be necessary in a fast track CAPA. And in the interest of being able to implement this quickly, and be able to get going with the CAPA pilot program, we didn't try to make any immediate modifications to our software system because we only have a couple of sites that are piloting the program, but this software system is a global system, and so any changes that we've made would be visible to everybody and potentially confusing to the rest of our sites across our organization. So we kept that part simple, and we have been, just completing that documentation within kind of a free-form area within our nonconformance management system. That requires us to have some more careful oversight to make sure that we're consistently meeting all of the elements required for corrective actions as defined in the regulations.
Okay, thank you. The next question I had was around the problem-solving culture. So how has the application of the CAPA framework impacted the problem-solving culture at your site?
Yeah, I'd say we're still early in this process. I can definitely see that more people are getting more excited about being able to make the changes, make those incremental improvements that they know are there and they know are going to be helpful, but that they were reluctant to do previously, just because of the oversight, the extra burden, just kind of the I don't know what to call it, the inconvenience, I guess, of having to put that in a traditional CAPA framework. We definitely are seeing that we are starting to be able to implement those incremental improvement solutions faster.
Excellent.
That's definitely occurring.
That's definitely what we're after with the framework. The last question I had for you was, what type of interactions or benefits have you seen as a result of the collaboration between the pilot sites?
Yeah, there's been a lot of benefit to that. It's easy within one organization to kind of create one single mindset, and almost have blinders on in terms of what you think is supposed to happen, what you think is the right way to do things. And so the forum that we have is a great place where we can bounce ideas off of each other, challenge each other, and really engage in that creative debate. And build off of the experiences that that people have had across different organizations in different situations, and use those collective experiences to create an overall stronger, more robust system. And that's something that by ourselves it would have taken us a lot longer, or maybe we wouldn't have even gotten there, just because we wouldn't have had the perspective.
The next question I have is for Marc-Henri. And this is really around our regulatory strategy. So as the team was putting together the CAPA framework and we were discussing what the pilot would look like, there was two things that consistently came up. And one of them was the regulatory strategy. So sites wanted to know, how is this going to engage with the current regulatory environment and what can we do? And so with that in mind, my question for Marc-Henri is, what regulatory strategy did the team have to support the sites going through the pilot? And you could walk us through that.
Well, what we made sure when we developed the strategy was to make sure that the framework would not conflict with regulations. And actually, it's not that intuitive, because I think some of the members of the working group were in the mind that the requirement would have to change. But we tried to know the requirements have that flexibility to adapt to different situations, and the framework was actually a good support for a risk-based approach. But beyond that, it was apparent that manufacturers' behavior is driven sometimes by the outcome of external pressure, like inspections or audits by people who maybe sometimes literally read the requirements too literally, and therefore pushing to extreme behaviors sometimes. So the working group made actually significant effort to clarify what those requirements are, as well as the interpretation that exists official interpretations by regulators, by the people who develop the requirements of the standard. So So among the topics that really came up as needed reminders of were the fact that, as I mentioned, risk-based approach is actually supported by both the US Quality System Regulation and ISO 13485, in its close code 4.2. And the basic fact that not every nonconformity requires a correction, not every nonconformity requires a corrective action, and that that guidance on corrective action and preventive actions developed by regulators among the Global Harmonization Task Force, the GHTF, that ISO 13210 that developed the standard that actually leveraged as part of their technical guide to ISO 1345, and that the requirements applicable to corrective actions and preventive actions are in both ISO 1345 and the US QSR apply where the analysis of measurement and monitoring data leads to a decision to implement the CAPA process. So this had to be reminded and clarified, and was not obvious to all that, including auditors, including investigators, that those are important features in the regulations and the standard. So beyond that, we have presented the framework to different audiences, especially to a group of investigators at the FDA to make sure they would understand and they had a chance to comment on it. Also, the technical committee mentioned before at ISO, TC210, that developed ISO 1345. The framework was presented to them during the last conference in October or November. And we also submitted them the white paper for comments. Eventually, we also reached out to the auditing organizations involved in the Medical Device Single Audit Program, or MDSAP, during the last annual MDSAP forum in December. And all of these groups actually provided rather positive and supportive feedback. So that was encouraging to move ahead with it. Beyond this, the organizations participating in the pilot were especially sensitive to the fact that the whole effort could be jeopardized by early negative outcome from auditor inspections at their participating sites. So we also reached out to the MDSAP auditing organizations that were specifically involved in the audit of those sites to make sure that they they were aware, they understood the framework, what we were trying to achieve, and what differences they could see compared to what they were used to audit before at the same sites. And we also developed different tools to support the participating site during an audit and to help educate further the auditors or investigators. We have recorded a training module that is available for them to watch if they need. Eventually, we set a kind of a hotline for them to reach out to either Bleta or I during an inspection or an audit if they feel they need some clarification on our end. Obviously, they can discuss with the manufacturer themselves.
Yeah, Kathryn, if I can also add, so during the time where we presented this approach to the auditing organizations and others, it became very evident that a lot of companies have implemented a risk-based approach, and this is not new to many, but many others, as Marc-Henri mentioned, have implemented a more conservative approach due to the different fears. We are continuously asking for and seeking input from different auditors and investigators in order for us to strengthen the framework that we've implemented. And just recently, we've made some minor tweaks of more terminology versus major changes to the framework. And so I think that on its own is evident that the framework is providing a lot of benefits to organizations, but it's also continuously to meet the regulatory requirements, both ISO and FDA, so 820 requirements.
Thank you. No, that's good. That sort of leads to the last question I had, and this one's for you, Bleta. And Marc-Henri alluded to this as well, is for an organization that's piloting it, What should they do if an auditor brings up a concern with the CAPA framework during the pilot?
So to some, I think we alluded earlier, the framework may look different. It may be something that, or an approach that they have not seen in the past, and that's okay. But we believe, and as we've gone through this process, the framework still meets the regulatory requirements. So as the organizations implement the pilot, as they get audited by an audit organization, we continuously request their feedback, their input. Marc-Henri alluded to the fact that we are the hotline when questions come up, that there's a concern. We're happy to engage with ORA, so Office of Regulatory Affairs, so the investigators from the FDA, or the auditing organizations that are auditing the organization, and continue to learn, to adapt or to make tweaks and changes to the framework. Again, this is a pilot, so we are continuing to learn and to incorporate any modifications that's required in order to meet everyone's expectations and to drive industry forward. So changes can be made quicker, which would lead to higher quality of products in the field, but also the important thing is adding the benefit to the organization so they can utilize a system that also helps them with that flexibility and agility.
Thank you, Bleta.
I'll just add in there real quick. I can vouch for the fact that hotline, it works. That was great. That was fantastic for us to be able to utilize that.
Yeah, that was excellent. Well, I want to thank each one of our panel members. I'm hoping that those of you guys who are listening have a deeper understanding of the pilot and what you might experience if you do decide to join us. But I wanted to thank everyone again for everything that you're doing to help move the program forward. So with that, I'd like to hand it over to Pat Shafer to talk about our next focus area.
Thank you, Kathryn. So a little bit of history about the leadership engagement working group and workstream. It was one of 4 topics or programs that were established in 2018 as part of the Case for Quality, identified by the steering committee. And it was originally called CEO engagement. And I think one of the first things that we did as a team was to change the name from CEO engagement to leadership engagement, because we feel that fostering a culture of quality and engaging employees in quality is a broader issue than just the CEO, and that all of leadership needs to be engaged. We also think that it's leadership's responsibility to foster or create an environment that supports a culture of quality. And this could just as easily have been named culture of quality workstream, because really that's what we're trying to achieve. Our belief is that a culture of quality can foster performance as well as quality and patient health and safety. So, this is really setting the stage for quality. We had quite a large team supporting us throughout the program. We had a number of people, as you see on the screen here, contributing information, helping shape the program. Those on the left in bold actually went the extra step and authored one of the 10 chapters that's part of the playbook that we're about to present. So I want to offer sincere thanks to everyone who participated in building this. On the next screen, you can see a little bit about our journey. We started way back in 2018, as I mentioned, right after the topic was selected as one of the 4 work streams, and created a program charter. And that charter set out our goal and our mission for the entire program. It set out a 2-year time frame, and our expectation was by the end of this year, Q4 of 2020, that we would have not only a program in place, but piloted and available for everyone. The first step, of course, was project planning, and as with the CAPA work stream, we felt it was important to understand the stakeholder group out there. So we surveyed a good number of corporations to understand where they stood on culture of quality and what areas needed the greatest amount of focus. The survey went relatively quickly. Getting people to respond took some time, but we did get the output around April of the following year. and then spent a fair amount of time after we used the survey to determine what the topics would be, spent a good amount of time collecting leading practice or best practices from all of the people that you saw in that previous slide. Once we collected those practices, we then started to author the playbook, each chapter representing one of the 10 areas that was represented, that was identified in the survey. And I must say that we went slowly through the authoring process. It was very difficult because everyone was a volunteer who had other responsibilities in their day jobs. But we finally put together an aggregation of all of the leading practice material and formed it into those topic areas. It looked something like a Frankenstein document with different types of input from PowerPoint, Excel, and Word documents, and other articles that have been published. But finally, the team was able to shape it into a cohesive playbook. At this point, the playbook is going to be complete by the time this video is being aired, and you will be able to download the playbook and actually pilot it. Originally, we were hoping to conduct a pilot during this time, but instead what we have done is provide a set of structured frameworks that you can use to pilot each of the 10 chapters when you download it. And our request is going to be that after you do pilot different sections, that you send the information back to MDIC so that we can review and update the playbook. Just a quick glance at the survey results. During the survey, we identified, as I mentioned, these 10 areas. Leadership felt pretty confident that they were already promoting quality. As you can see, 91% agreed or strongly agreed. Fewer felt strong that they promoted or prioritized quality over cost. And where we saw some real gaps, though, over on the right, and where the greatest focus needs to be is around focusing on prevention over reaction. 53% disagreed or were neutral that their companies were promoting or focusing on prevention over reaction. Even fewer formally measured cost of quality. So, these were areas where we felt that the work that we could do would be very valuable. One of our insights was, and you'll read that as you go through the playbook, that employees don't necessarily agree with leadership. So most of the respondents of this survey were leadership. And our observation as a team was that while 91% believe that they promote quality, the employees may not feel the same way. So I think that's something that needs to be addressed as you take this forward. On the next slide, I want to give you a brief glimpse of the piloting practice. So each chapter is going to create insights into how to pilot that particular chapter. First of all, of course, defining the scope of the pilot, establishing a baseline. There's some guidance around how to conduct the pilot, how to measure success, and then, of course, drive continuous improvement. So we hope that people who are seeing this will download the playbook and, as I say, start to pilot one or more of the good practices that are in the playbook. These are the areas: strategy, leadership communication, quality in my role, prioritizing quality, quality behaviors, prevention versus reaction, metrics, performance reviews, benchmarking, and finally measuring the value of quality. These are the 10 practices that have been written up and that you are available for pilot. I'm going to now turn it over to Jackie Torfin to start to take us through the different chapters.
Thank you. So we're starting with quality strategy. As it says on the screen, it's really kind of the first milestone as you develop your culture of quality. The quality strategy really has to be aligned with the company goals. And it's really how you're going to help your company to achieve its goals. Thinking about how that might look. If your company goal is to improve your EBIT, pretty standard company goal, we're going to improve our EBIT. It would be important to think about, from a quality perspective, how does that look in supporting that goal? An experience that I've had in the past, improve company EBIT. The production, the operations team has decided one of their goals to support that overall company goal is going to be decreasing the cost of goods. And as they're focusing on decreasing the cost of goods, they are thinking about how they're going to minimize scrap. In parallel, my team is looking at how we're going to help decrease EBIT. And because we're very data focused and we like reporting, and my team was thinking about, it's probably a good idea to maybe work on a goal of increasing the visibility to the scrap cost. So we're going to improve the reporting. Well, what ended up happening, although it seemed like it was aligned, if we dug down a little bit deeper, what we found was by improving the visibility, and it almost sounds counterintuitive, but improving the visibility to those scrap numbers, we were actually, unfortunately, kind of giving the production team a feeling that they needed to stop reporting the scrap as well. So they stopped actually reporting as many nonconformances. So things that in the past they'd say, oh, that's a nonconformance and we're going to do that, which would lead to some scrap potentially, started to fall to the wayside, and reporting of the NCRs got a little bit worse. So instead of, hey, we're going to help improve the cost of good scrap, a better idea could have been for us in our quality strategy to go after helping to decrease scrap from the get-go. So we stopped. We were about a third of the way through. We recognized this was happening, and we stopped, and we changed our quality strategy to implementation of 5S, and to try to actually get on the floor with production and improve the scrap processes itself rather than improve the reporting. So that's just kind of a real life example of how not aligning the quality strategy completely well with the rest of the business can drive the wrong behaviors. Leadership communication, I like to look at this particular chapter really as facilitating the culture of quality. Really speaks more to what this entire chapter is about. How do you help facilitate that culture of quality through good communication and good leadership practices? So I'm going to talk a little bit about just instilling accountability for quality and empowering employees. One of 10 steps. This really means walk the walk if I'm a leader. And how do I think about driving accountability through the way I communicate down to the lowest levels? So really encouraging critical thinking down at the lowest levels, which, by the way, is pretty scary, especially in a regulated industry. Do I really want the lowest level of my team to critically think, to not follow, because critical thinking kind of goes against the just follow the procedure. Don't ask me a question, just follow the procedure. But unfortunately, that gets us to places where when our procedures aren't actually set up for every single potential situation, we're not making good decisions because we're not teaching people how to critically think. So it's all about how you're driving that accountability down to the lower levels through facilitating that culture of quality. The next chapter's talking about quality in my role, which is building on that facilitation of the quality culture through leadership communication. So it's understanding, where do I fit? How does my job and what I do, my maybe invisible role of I'm a packager or I work in facilities, how is that role critical to what it is that we're doing as a device company to manufacture and distribute excellent products? One of the ways that we talked about and that we outlined in the playbook to doing this is really creating great connections between the employee and the output. So training activities or events where you're seeing the output of what it is that you've all done together. So patient testimonials, there are some companies that do an excellent job of this. Some of the larger companies have entire weeks or days built on quality and talking about having patients come in and give testimonials to, hey, I have your device inside my heart, and this was a big deal for my family, and everything that you did made sure that it was safe for me. And so just connecting those dots between what it is that each person in the organization does and how it creates success in your med device is really important. So the next part of our leadership engagement playbook is really talking about how management can prioritize quality. Sounds pretty easy. What we're really talking about here is how do you move quality from the big Q, meaning quality as a department or quality as a thing, and moving it to really quality as a little q, or quality behaviors and practices in everything that I'm doing. How do I move from compliance and following my SOP and following the regulation to thinking about quality, the little q, in every single action that I'm doing? How do I get it to continuous improvement? So really, when we're doing that, it's critical for us to use the data. We've got to use the science and the data to help us drive to a better place. For me, one of the best examples of this in our industry right now is the initiative we just heard about, MAKECAPACOOL, where we have gone beyond the regulation. The regulation is fairly simplistic, and yet it's one of the top warning letter observations every year. So why? We've taken a step back as an industry, and Kathryn and her team have done a great job of saying, all right, what does the data say? Where is the science leading us? And how do we take CAPA and use our brains and continuously improve to drive the right behavior, right? Instead of just following the procedure. That to me is a great example of moving from compliance to continuous improvement. Talking about quality behaviors. So as we said earlier, quality culture really needs to tie to your company's mission and vision. So you really have to be clear in your organization what behavioral expectations you have in order to drive that quality culture. In our playbook, we give this one example that we have on the slide here around one company's journey for identifying specific behaviors, and they identified 4 specific behaviors: accountable, courageous, patient-focused, and preventive. They all speak very clearly to what their overall mission and vision was. And then they took those 4 behaviors and they turned those into I statements. So what does it actually mean personally to each person on the floor, in management, in leadership? So it's things like saying, I will follow through on making decisions based on facts and data, or I will do what I say, I will do. So it's just each company, and we're talking about how do you identify the right behaviors as it's related to your mission and vision, and then how do you distill those into very personal messages for each of your employees. So at this point, I will turn it over to Rama to take us through the next several slides.
Thank you, Jackie. Continuing on from what Pat and Jackie has touched upon, we have a few more chapters in this book, which is to engage the leadership. We felt that prevention and reaction is a very important topic, and it can be more to catch the things that you can do early on. The cost of redoing or anything much later on is very expensive, and there have been many studies about that. So what we felt is lean and continuous improvement program, and all these are there probably in a lot of companies. They can drive a sense of prevention. And also quality management system has CAPA and other systems that will have about a sense of even FMEA would be very good, which is a failure modes and effects analysis, as well as instilling a sense of how failure modes can be identified or anticipated to prevent them. In that sense, there's also a sense that a quality can participate in the new product development early on, because from my experience and experience of others, it's been felt that failure modes can be better imagined by people with a quality sense, and that can be instilled also to prevent than to react much later on to make it more expensive. And supplier quality and supplier selection and process capability is another area where material selection and all those things are definitely very important in the sense of preventing of product failures. The metrics, again, we all know that what you cannot measure, you cannot improve on. Probably you heard this. And we felt that what you measure is and tied to a purpose is very important, not just measuring for the sake of measuring. And some of the examples that I can think of is in the early days of e-commerce, sites used to measure how many people hit their site, they found that to be useful not for how many people can buy stuff for revenue generation, for example, whereas it is very important to know if it is good for load balancing and other things. So the purpose of what you're measuring is very important. And in this sense, we're saying that you need to define a clear purpose for measuring, create dashboards, quality metrics dashboards, and quality metrics dashboards can be internal and external. Internal is all about your product design and manufacturing. External can be about how the product performed in the field, complaints and CAPAs and other processes. So creating a dashboard for quality metrics is extremely important to drive behaviors, and the feedback from these can be used to drive better quality behaviors. Performance reviews. Again, these are broken into 3 buckets. The idea is to have a peer-to-peer performance review. The idea in the peer-to-peer is to create a blame-free environment to provide honest feedback so that people are able to understand when something is being told that they're not being criticized for something, but it's only an honest feedback that can improve the quality. This will also be more about, say, a group and individual accomplishment. It has to be both positive and negative feedback. It's not just negative criticism or anything. Then the manager recognition program, manager can play a role of both being a monitor and mentor. In the sense of monitor, continuously monitoring performance of the people who report to them. And this will again be the team performance that can be enhanced by having this kind of framework. Whereas a leadership engagement and the performance review is how the individual is impacting on the product. And this is about the customer feedback on the product. As Jackie has alluded, how the patient has been helped by this product, any positive feedback can be a lot more useful incentive for better performance. So now we come to quality benchmarking, and this is really about how do you measure with your competition. And this can be both qualitative and quantitative. And the way this can be measured, we have a pilot framework that we have highlighted here. But what we found is by collecting the information, what is the purpose you're going to do the benchmarking for, and what prioritized area you're going to be benchmarking for is very helpful. And you can standardize on these things, but the most important piece among the benchmarking topics would be baselining on people, process, and technology. Among people, it could be qualifications and skills and training material. And I have seen that there is a lot more technology infusion into the training itself using, of course, computer-based training is very old, whereas augmented reality and virtual reality are the areas where there's a training that can be significantly different. And in the process, of course, it'll be all the processes of all the management system, which is going to be the design, risk, and validation, CAPAs, and complaint handling. These are the areas that you can benchmark against your competition. But make sure that the competition you pick to benchmark are of your own class. So it doesn't make sense to have a class 1 device go and get benchmark themselves against a class 3 device, which is a lot more complex. And in the technologies they have chosen, all the electronic systems that are there to support all these quality and the R&D business processes, you need to do some validation of how these are effective in terms of being cost effective. So conduct your benchmarking by collecting the information, doing a data validation and analysis of the data that you have to see how you can add cost effectiveness for this. So now I'll hand it over to Pat.
Great. Thank you, Rama, and thank you, Jackie, for taking us through those different chapters. The last chapter that we want to talk about is measuring the value of quality, which actually is derived from content that was developed at an earlier MDIC FDA Case for Quality initiative, and it was the competency work stream. There's a fair amount of material in here which will help companies create a framework for measuring the value of quality, but I just wanted to highlight a couple of issues. One is that companies typically underestimate the cost of poor quality. We're all aware of internal failure costs and external failure costs. There are formulas and standard practices for measuring those. But what we found was that companies don't really have a true appreciation of the impact of poor quality on the entire ecosystem. The impact of poor quality on healthcare providers, that insight was provided by people who from that provider segment who have felt the impact. Talking about income loss related to procedures that weren't performed because of quality issues, costs related to repeat procedures, or in some cases, fines and legal fees because of impact to patients. So that's significant. We also had participation of the FDA, of course, and they delivered some metrics around the additional hours alone required because of monitoring where there had been failures. So the cost of poor quality is significant, goes far beyond just the manufacturers themselves. The other thing is that we found that very few companies measure the benefits of good quality. And this is, I think, problematic because there's only so much cost you can squeeze out of the failure side, but there's no limit to the upside in terms of revenues generated if you do quality right. You make a good quality product, and as the value assessment committees, analysis committees rely more and more on the value, they're going to be investing in products that have good quality. So at this point, we want to turn it back over to Alan to ask a few questions of the panel.
And now we do have some questions for the panel. So I'd like to start with, how can we be sure that the ideas outlined in the playbook are best practices?
Well, I'll jump in and then ask my colleagues to jump in as well. I think the benefit of having an industry consortium work to define these practices, these were collected from the top names in the medical device industry. They reflect what these leading companies have been doing. So I think it's the assurance of the breadth of participation in the process.
Yeah, and I'll add, one of the things that was really important to me, having been a head of quality and regulatory at a couple different companies that weren't the biggest companies, it was very important to me for it to be balanced, not just if I'm a big company and I've got a lot of resources, we can do a lot of stuff. It was really looking at some of the more intangible things that leadership can do that wouldn't cost a whole lot of money for the smaller and medium-sized companies, because those companies have usually, in my experience, less of a focus. They're maybe not talking to the street, and it's not necessarily an externally funded company, and they're possibly less focused at the leadership level at driving those quality behaviors because it's just not a priority at that point in their company continuum. And yet it's probably the most critical for those smaller and medium-sized companies. So I felt really good about the fact that we were making sure that we were getting small and medium-sized companies input as well.
I'd like to add that the best practices are also taken from cross-functional industry areas like aerospace and automobile. And there also safety is very important. And some of the fundamental ways of approaches is failure modes and effects analysis, and doing a risk management, risk assessment, all those things are common. Those are the best practices in those industries also, still tied to the safety of the traveler, and here is the patient. Thank you.
Excellent, thank you. So next question is, how long should a pilot last?
You know, I think that the pilot, the way that we put the playbook together is with different pilot options for each of the different chapters. And so understanding that leadership engagement is really, it can be a fairly long journey, and it's very complicated. There's lots of different things. It's interesting when you read the playbook, sometimes you're thinking, wow, wait a minute, I think I heard that same thing a couple chapters ago, because it's all very interconnected. So I think the pilot should last based on how many of the engagement practices you want to try and put into your organization. Each one is, because we're talking about measuring baselines and measuring information, I can't imagine that a pilot for any of the different sections would go less than 6 to 12 months, would be my guess.
And I would agree. You know, culture does not change overnight. And in order for culture to change, if leadership is leading the charge, they need to build credibility. They need to walk the talk, as it were, and that doesn't happen overnight. So I agree with Jackie's assessment, probably a minimum of 6 months. I do think that it's so important, though, to use the guidance and establish that baseline, because it would be a waste of time if you started implementing the practices without really understanding the true impact, and only through measurement can you achieve that.
Right. Very helpful. Thank you. So for the audience, what stakeholders beyond the quality organization could participate in the pilots?
I'll jump in. So much of this culture and changing culture is HR related. So at a minimum, working with the human resources organization to come up with the measures and provide the technology or the systems to measure it. Our quality systems, which measure CAPA aging and deviation counts and all that, that's not going to provide the insight necessary in order to measure culture change. And so, you know, at a minimum, looking at manufacturing performance, looking at HR indices and others, I think is going to be critically important. It really needs to be a partnership to achieve success.
That's very helpful. Thank you. So what sort of feedback are you expecting from the pilots?
Rama, what would you like to see?
I would definitely like to see tangible stuff, which is metrics and benchmarking, which is more tangible. Quite often, it's easy to convey to the leadership that these are tangible benefits you can see, and also it could be on the cost of poor quality and how much you'll save by implementing some of these better practices is what I think would be more easy to convince to invest in quality, especially this is a leadership engagement program. We need to convince them, and that's what I would think.
And I'm really looking, I'm hoping to get feedback as to where it failed. I think understanding if there are companies, especially with the hat that I wear, with the smaller to medium-sized companies, you know, I'm located in Medical Alley in Minnesota, and we've got lots and lots of very small startups. And for me, I want to see some startups and some smaller companies try and begin with the end in mind, right? So I would like to see some of those companies pilot some of these things. And then I want to hear what didn't work. What was really kind of, and I've been saying this to Pat the last several weeks a lot, what is coming across as blah, blah, blah. Okay, that's really nice that you wrote it. And what's really working and what's really helping us to improve our culture and improve the ultimate delivery of the product to our patient, because that's the only thing leadership is truly going to be engaged in, right? It's got to help at the end of the day. And I don't need a cheerleading playbook. I need a playbook that tells me how I can improve some stuff.
Very helpful. Thank you. So lastly, where can we find the playbook?
I think I would turn that over to you, Alan. I think that we will be finished. There will be a version that's been written and edited by the great team that's been working with us, and it should be available on the MDIC website as far as I can tell.
Absolutely, very fair. It will be available on the MDIC website under Case for Quality Initiative. We'll also be making an announcement when it's available on the website for download and reading. And we'll likely have a method for folks to reach out and submit inquiries for additional information or help in some way. So thank you very much. I think that was just a wonderful panel. I'd like to thank the panelists again. That was very informative and helpful. And on behalf of myself and MDIC, I thank all of you for your participation on these wonderful panels. It was just fantastic. This has been very helpful on highlighting the progress in reshaping CAPA as a risk-based continuous improvement process and how to more effectively engage leadership in improving the culture of quality in organizations across the industry. And on that note, thank you very much. Have a wonderful day, and please tune in to the remaining MDIC annual public forums. Thank you.
Thank you for attending MDIC's annual public forum. We hope you will join us for next week's session for further updates on Case for Quality, including the Voluntary Improvement Program and initiation of the Medical Device Information Analysis and Sharing Program. Visit apf.mdic.org for more information and to catch up on previous sessions.